The following episode is brought to you by the American Urological Association. This episode features content from the AUA 2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support has been provided by independent educational grants from AstraZeneca and Merck & Co. Incorporated.
All right, good morning, everyone. Thank you for joining us. Feel free to move up if you want. We're hoping to have kind of a informal discussion about PARP inhibitors, no slides. This will be kind of a warm-up for the rest of the day when we are learning about the evolving landscape of advanced prostate cancer. But this morning we'll focus on PARP inhibitors. We have microphones set up too, so feel free to ask questions throughout. I have to read some housekeeping notes for y'all. So welcome. The AUA strives to offer outstanding educational courses and greatly appreciates your evaluations and general feedback. So you will receive an evaluation after this. Please fill it out. The AUA would like to thank the following companies for providing independent educational grants in support of this educational series: AstraZeneca, as well as Merck & Co. And I want to thank our esteemed faculty today for their time and expertise and commitment to this outstanding educational program. First, we have Dr. Alicia Morgans. She is prostate cancer guru, associate professor at Harvard Medical School, and a GU medical oncologist and medical director of the survivorship program at Dana-Farber Cancer Institute. She's a clinician and an investigator. She has experience and expertise in clinical trials and patient-reported outcome measures. And then Dr. Kelvin Moses. He is the holder of the Joseph A. Smith Directorship in Urologic Oncology. He's the program director for the Urologic Oncology Fellowship at Vanderbilt, and he's an associate professor. Professor? You? Associate. He's getting there. And Dr. Moses also does a lot of patient-centered outcomes research in prostate cancer, as well as healthcare disparities and health literacy. Course faculty, education counsel, and COI review workgroup disclosures are located on the AUA 2025 website. And then evaluations are super important. So please evaluate us on this course and the content. We really do hope you enjoy it. All right. So we do have some learning objectives today. First, to apply the mechanism of action of PARP inhibitors and the rationale for using them in patients with advanced prostate cancer. Second, to recognize the role and importance of genetic testing in patients with metastatic CRPC and the implications of germline mutations on response to therapy. Then identify best practices and utilize available guidelines for patients with metastatic CRPC to optimize treatment success and oncologic outcomes. Recognize when to use PARP inhibitors as monotherapy and the rationale and indications for combination therapy and appropriate sequencing. And then finally, to successfully counsel patients on the possible adverse events associated with PARP inhibitor therapies alone or in combination. And we'll start off by just talking about the mechanism of action. We know that PARP inhibitors have been around for quite some time. They're not a new class of drugs, but they're relatively new when it comes to the management of prostate cancer. So Dr. Morgans, can you tell us a little bit about PARP inhibitors, why we use them, how they work?
Sure. So PARP inhibitors, at least as single agents, have been most useful because we think of them as really helping to stop DNA repair processes that are normal parts of cell replication. So when cells are replicating, there can often be these single-strand breaks where PARP enzymes come in and they try to repair those breaks to prevent the buildup of a bunch of DNA damage that then could cause the cell to die, and because it's not functioning. So when we inhibit the PARP enzymes from doing that repair process, we're actually causing this buildup of single-strand breaks, then leading to double-strand breaks, and cells really undergo this process where they're not able to function because of that accumulation of mutations, and they end up being inactivated or essentially dying. So PARP inhibitors that are able to stop that DNA repair process help us to kill cancer cells. And again, it's really as single agents thought to be most effective and demonstrated to be most effective when patients already have these sort of damaged processes where the backup systems are not going to be there to pick up the slack if we inactivate the PARP enzymes.
So our normal healthy cells have these PARP enzymes normally helping to function and repair genes, and when they're damaged, that's when we can kind of capitalize on that from an inhibitor standpoint. All right, so an important part of this is genetic mutations, and you'll hear about that throughout the course of today's discussion in the evolving landscape. Genetic testing has become increasingly important, and our understanding has really changed and improved. And so, Dr. Moses, can you talk to us a little bit about the frequency of both germline and somatic mutations in patients with prostate cancer?
Yeah, definitely. So there have been several landmark studies, really starting in about 2015, that looked at the frequency of genomic alterations in metastatic prostate cancer. In 2016, there was the Pritchard study in New England Journal looking at germline alterations, and they showed 11.8%, about 12% of men with metastatic prostate cancer harbored these alterations. And they were most frequently in BRCA1 and 2, ATM, CHEK2, PALB2, and several others. And that's in comparison to about 4 or 5% in localized prostate cancer. So it's more than double in that setting. And then in Cell in 2015, there was a publication on somatic, so alterations that are seen in the tumor itself. And in that review, they found 19%. If you look at multiple studies, it's somewhere between 19 and 23%. In Talipro, so Talipro 2, it was at 21%. So that would be the number. And again, the rate of alteration, particularly in BRCA1 and 2, is even higher. So among that population, about 20% of those are BRCA1 and 2, and then again about several other genes that are associated.
Yeah, it's really been in the past several years that we've seen the indication for germline and somatic testing pop up in our guidelines, both NCCN, AUA guidelines for patients with prostate cancer. And that's kind of across the whole scope or kind of treatment landscape for prostate cancer, including patients who have localized disease and a strong family history, or those who have findings of cribriform or intraductal morphology. And so I think we've become more comfortable talking to our patients about genetic testing. And I don't think that the kind of shortage of genetic counselors that we've all heard about should be a limitation in ordering these tests for our patients, because they do have important implications. And I'd like to hear from both of our panelists about what you're doing at your institution, how you're talking to your patients about germline and somatic testing, and how you counsel them on the possible outcomes and what that means. Because I think we as urologists and certainly medical oncologists need to be facile with having this discussion. I don't think we need to be experts when it comes to all of the nuances of genetic counseling, but we need to have an understanding of why we're doing it and what the implications are for our patients. So Dr. Moses, I'll start with you.
So yeah, just kind of follow up on what you were saying. So there are multiple guidelines that discuss germline and somatic testing in advanced prostate cancer. They're not quite harmonized, so between NCCN, AUA, ESMO, ASTRO, there are some differences, but in particular NCCN recommends germline testing in anybody with high risk or worse prostate cancer, so high risk localized, very high risk, regional or metastatic disease, and then certainly in any of the CRPC states. As far as somatic testing, for the most part, that's recommended in metastatic hormone-sensitive prostate cancer and beyond. And really, as was mentioned before, it indicates, number one, what medications people are eligible for, but it also indicates the familial risk overall. So many of our patients will say, okay, well, do my sons need to be tested, or brothers, or whatever? And so you can get that kind of information. So we want to be getting a good family history, and it's really important to ask about not just prostate cancer, but have multiple women had breast or ovarian cancer? Is there a strong history of colorectal or upper tract cancer indicative of Lynch syndrome? Are there a lot of early diagnoses of endocrine or pancreatic cancers? NCCN is coming out with, or maybe they already have, a guideline of genetic testing just in general for cancer. But certainly in the advanced prostate cancer space, there's a lot of good information that can be gleaned.
So when it comes to the practical application of these kinds of guidelines, I think we all have to think within our practices, how can we make this work? And I think that's one of the biggest challenges. And Kristen, you kind of alluded to this, that there are concerns that we've had over years that maybe we don't have genetic counseling support, or we don't have the ability to take care of the patient's needs after we get the testing. And I think the time has come for us to get over those concerns and really think about how do we actually make it work, because the guidelines have been in place for a while now. And germline testing is the other piece of this, and that's the one where I think we have a little bit more hesitation, because germline testing is done so that we understand that family risk, and then we do have an obligation to have the patient connect with a genetic counselor or some knowledgeable individual in the practice to make sure that they then can have those conversations about, should we do cascade testing, that family testing for their sons and their daughters and other relatives, brothers, sisters, and others. So when it comes to germline testing, in our practice at least, we have a couple avenues that we can take. One is a rapid testing approach where on the day that I see somebody, if he is willing to do the germline testing, I have a program where I can just connect him directly with, they're not genetic counselors, they're genetic sort of research, or genetic coordinators is what they call them. So they can counsel patients on the basics of, we're doing this testing to understand both your treatment opportunities and your family risk. They get a little pedigree of the patient's family history, and then they send them for testing right then. That's the extent of the counseling they give. And actually, I give the same counseling in my clinic before I send them, which is, just as I said, this is to inform your treatment options and your family should we identify something. I think as a physician who takes care of people with prostate cancer, that's the gist of it. I think if they have follow-up questions, you can share that the percentages that Kelvin shared, the likelihood of you having localized prostate cancer and then having a germline mutation that's causing that cancer is only, say, 5-6%, so the likelihood's low. You can share the percentage for metastatic disease, around 11%, as he said. But usually people feel pretty comfortable with that information, and then we can get people to a genetic counselor on the back end. And many of the testing companies actually offer that genetic counseling via Zoom or other support through their systems. And I think practices that don't have genetic counselors embedded within them can really rely on those experts. And in other practices where I've worked, that's what we've done, because not every practice is going to have a genetic counselor sitting with them in the clinic. So that's one of the main ways that I go about testing. If a patient has a strong family history, I have access to a genetic testing system that's adjacent to that with an actual genetic counselor, because when people have really complex family histories of cancers, not just prostate cancer, sometimes the genetic counselor will think about expanding the genes that are tested. But that's a rare patient that I end up sending there. And most practices, unless they're in big academic centers, probably don't have access to that. So this sort of general counseling, and then having that workflow in your practice with a plan for genetic counseling, maybe through the company on the back end, I think is one of the best ways and most practical ways that I've seen the germline testing applied.
Yeah, I would reiterate that too, but we'll talk about it in the next session. But if you want to integrate this into your practice, it's relatively straightforward, depending on what depth of screening you want to do. we're lucky at Vanderbilt when Dr. Morgans was there, and now Dr. Scarpato is running our comprehensive prostate cancer clinic. So on the urology side, we'll do the germline testing, and we use Tempus. I don't have any disclosures with them. And for those who get somatic testing, it's done through the medical oncologist. We use Invitae. And then the medical oncologists use Tempus for the somatic testing. A lot of the companies are here now. So if you're looking at integrating it into your practice, it's actually relatively straightforward. Certainly for the germline, I mean, it's a blood draw. And then, for somatic testing, if you have access to a biopsy or pathology, you can get a hold of that. They give you a pretty easy for us readout. It is a little bit complex verbiage on there, so you do have to do a little bit of explaining. Probably one of the major frustrations is when you get a whole list of VUS, variants of unknown significance. That can be a challenge because, the patients can freak out. They're like, oh my God, my set D2 is mutated. Oh my, it doesn't really mean anything, but whenever we see these variants, there is an explanation of what it could be associated with, and that, again, is where we utilize our genetic counselors and say, okay, I wouldn't worry about this too much. It's certainly not related to your prostate cancer. Maybe we need to do more screening, colorectal or lung or whatever else, but at least for the VUSs, that's not something that really changes our treatment paradigm or prognosis or anything like that. It's really BRCA2, 1, ATM, those are probably the big three, and then sort of CHEK2 and PALB2 are going to be the next up. But that information is helpful when you're making these treatment determinations, particularly in patients who progressed on therapy.
One more thing I would add, we used to use a lot of Invitae testing. Just the way our system is now, my practice doesn't use that as much. They also have a saliva test, and that's another way that we often did testing. So if a patient didn't have time to stay for the blood draw, we could sign them up, and then I think either we gave out the kits or the kit could be sent to them at their home, and that's another way to get this germline done in a really practical way. If your practice doesn't have the workflow to get them in for a blood draw for the genetic testing, there are saliva kits available with at least that company. I would imagine other companies have it as well that can be helpful.
Just one more thing, Dr. Morgans, when thinking about somatic testing, so tissue testing, tumor tissue testing, you can biopsy a metastatic site, you can biopsy the prostate, or you can use ctDNA. What is the difference? Is one better than the other? And how often are they in sync, the germline and the somatic? Like, why do both?
Yeah, I think we, and the guidelines recommend doing both. We try to do both too. I think there are a number of practices that especially in Europe, where there are concerns, as we should all be concerned, I think, about overutilization of testing. They often talk about getting a tissue-based test and then reflexing to germline if there's something identified in the tissue-based testing, the somatic testing, that suggests that there could be a germline variant for somebody as well. So if there's a mutation that looks like it's prevalent in at least 20 to 50% of cells, then sometimes that would be a higher likelihood that this is also going to be in that patient's germline genetics. And in that case, there can be a pretty high concordance between germline testing and the tissue-based testing. But especially as this testing has evolved, and because we know that no test is going to be perfect and correct 100% of the time, it's recommended usually that we do both germline and somatic testing for patients. I think also, depending on your practice's workflow, germline testing, at least when I first meet a new patient who qualifies, and that's going to be a patient with high-risk localized disease, very high-risk localized disease, or metastatic disease, on the first visit, we're talking about this already to inform, again, their options should they need them in the future for treatment, as well as that family risk. And that's really a pretty easy thing to just check the box on a new patient visit. And then somatic testing, sometimes we do when they get that metastatic disease, metastatic hormone-sensitive disease, or mCRPC if it's not been done already. So it's going to be just implemented in a different time, and it's nice to know that we can have the opportunity to do that follow-up testing. To Kristen's point, I think both tests are currently recommended. Figuring that out in your workflow, as I said, can be helpful. But then you're also looking at different points in time for different things, family risk being so important at that first diagnosis. But then if you do need treatment options, sometimes you want to do either a ctDNA test or a metastatic biopsy, because you may imagine that you've exposed this patient to certain treatments and now maybe new mechanisms of resistance may have evolved, that you want to do a repeat test or a new test at that time from the metastatic site or the ctDNA, so that you get something that's had selective pressure to cause the mutations to develop. For most HRR mutations, they're actually what we call truncal, so they're actually going to be present in the primary prostate tissue, and they're driving that initial tumor from the get-go, so they will be there, but you can see 5 to 10% of patients over time kind of getting these additional mutations. It's actually probably even lower than that in most series. So using the primary prostate can be helpful. If you're a urologist, you probably have the tissue around, so that's also helpful. Sometimes I have to request the tissue from the prostatectomy, many years ago, which can be challenging. But if you have the tissue, using the primary prostate can be a good option, an easy option. If you don't, or if the patient has bone-only metastatic disease, we often do ctDNA testing because it's just a blood draw, and we think there's probably a higher likelihood of success rather than doing a bone biopsy, which can have variable success rates. Some people finding success rates as low as 30% on these bone biopsies in terms of getting tissue that's going to be adequate for sequencing. When it's up and running really well in your practice, still you're probably going to face 60 to 70% of the time having success, but still it is challenging sometimes for bone-only metastatic disease. So long answer to your question, but the point is, look at the distribution of metastatic disease, try to figure out, do I have easy access to the prostatectomy? Maybe that's the best way. Metastatic site if you can get it easily in soft tissue, and ctDNA if all else fails.
So genetic testing, really important for us to understand who's going to respond to PARP inhibitors, as well as familial cascade testing and kind of overall aggressiveness of disease. Right now, there are 4 FDA-approved PARP inhibitors for patients with advanced prostate cancer, either alone or in combination, and we're going to get into some of the data here now. But I wanted to just start by asking Dr. Morgans if there's any difference among these 4 in their mechanisms of action or affinity or kind of side effects when we're considering these.
I think generally we think of them as being relatively similar, especially when it comes to side effect profiles. Some of them may be having a little more anemia, some others having maybe a little more thrombocytopenia, but all of them need to be watched for cytopenias and sort of the GI, nausea, fatigue type side effects. So in that way, they're kind of similar. If you look at the trials, though, and you look at some of the early data in terms of just like the PKs and that kind of thing, it does look like there are some differences in the degree of PARP trapping or the degree of affinity for the PARP enzymes. So I think whether that comes to bear in your practice is something that I think each of us needs to decide on our own. And often I think that we can make decisions around which PARP to use based on the indication, where we have rucaparib and olaparib available to us when we're using single agent PARP, and then the combinations in first-line mCRPC being different partners and different drugs, so Abi and olaparib or Abi and niraparib versus enzalutamide and talazoparib. So the indication, the setting kind of helps us make those decisions. And I guess our own familiarity and comfort maybe helps us also understand and choose between these agents that may have some small differences, but it's hard to say 100% without head-to-head comparisons.
Yeah. And there are some newer PARP inhibitors that are being investigated. One called suraparib that is being touted as kind of best in class, and we're seeing them move earlier up, as we do with many of these drugs for advanced prostate cancer, starting kind of end stage and then first line, and then now maybe in metastatic hormone-sensitive prostate cancer. So kind of exciting, and we'll see what happens there. But let's get into some of the data. So in 2020, we had 2 of these agents approved by the FDA for use in second-line setting, single agent olaparib and rucaparib. So Dr. Moses, can you tell us a little bit about those approvals?
Yeah, so in PARP monotherapy, there's 2 critical trials, PROfound as far in relation to olaparib, and Triton-3 for rucaparib. Rucaparib. So PROfound was olaparib versus Abi or Enza in men who had progressed on novel hormonal therapy. So at the time this study was designed, it was pretty well standard. If you had advanced on Abi, you would just switch to Enza. And we know now that maybe there's only about a 10 to 20% response rate, but at the time that was the standard. So these were men who had progressed on one of those medications. They were randomized to olaparib or switched to Abi or Enza. And they had 2 cohorts, so they had a bit of a selected group. So cohort A were those who had BRCA1 or 2 or ATM mutations, and that's sort of a purified population. And then cohort B was any of the other 12 next most common genetic or genomic aberrations. And what they found, at least in cohort A, was a significant improvement in progression-free survival. It was about 3 months difference. And the hazard ratio for progression or death, it was a 66% reduction in risk of progression or death in the olaparib group. There were some adverse effects seen, as Dr. Morgan said, anemia is the main one, and fatigue, but relatively well tolerated. The narrowness of the curves, if you go and look at the paper, there was a pretty good amount of crossover as well, up to about 80% of patients. So even with that amount of crossover, you still saw a significant difference. So that's what led to FDA approval for olaparib in BRCA1 and 2. And then Triton-3 was another phase 3 trial looking at rucaparib versus Abi or Enza or docetaxel, again in men who had progressed with mCRPC. And again, you saw an improvement in progression-free survival, and that difference was about 5 months. So again, but there's some crossover from some of the patients. And this again, it led to approval for rucaparib. So again, that reiterates why we do the genetic testing. That gives our patients some hope because they've been on these hormonally based therapies all along, and now they've got something that may even be better tolerated, compared to certainly, Enza or docetaxel. The AE profile is going to be quite different. But we do need to watch for the cytopenias, anemia, nausea, vomiting, fatigue. Those are going to be the things that you see in these patients. Fortunately, that does not lead to a lot of hospitalizations. The grade 3 and higher AEs are relatively uncommon.
Great. So importantly, these were patients who had progressive disease, metastatic CRPC, had prior novel hormonal therapies, and all had genetic mutations. So patients were enrolled if they had mutations, and they're slightly different in each of the studies, but that was part of the enrollment criteria here, and we do see improved radiographic progression-free survival seems to be the primary endpoint for most of these studies, and as the data matures, we look for overall survival advantages. But we then see them now moving up into the first-line setting. So for patients who have not had prior docetaxel in the metastatic CRPC setting or novel hormonal therapies. And so Dr. Morgans, can you talk to us a little bit about the 3 important studies here in combination?
Sure. I think these are some of the more recent studies that we've been really excited about to use the PARP inhibitors in combination with AR pathway inhibitors. And The idea here is that, these are two mechanisms that we can kind of combine, and if we're inhibiting the androgen receptor, we can in many ways induce this BRCA type phenotype where there's a down regulation of those DNA repair genes, and so maybe if we then are able to put a PARP inhibitor into the mix, we've already kind of inactivated DNA repair. Now we're further inhibiting DNA repair. Those breaks build up and these cells will die. So the thought is that the combination may be more effective. And interestingly, I think that there's also always this question, is the combination only effective in patients with HRR mutations, or is there perhaps some opportunity for patients to have this synergistic benefit from these two strategies even when they don't have mutations? I think that discussion continues to occur, but the 3 trials that we have currently led to approvals for patients who have these DNA repair defect mutations, and so I just want to make sure that's clear. So one of the initial studies that was reported out was the Magnitude trial, which was looking at the combination of abiraterone and niraparib versus abiraterone alone in patients who had mCRPC, and they hadn't really had substantial exposure to an AR pathway inhibitor before. And these patients, importantly, I think, were selected on the front end of this trial to either have those HRR mutations, that was cohort 1 or the first cohort, or maybe still have wild type, no mutations, and that was a second cohort. And the randomization that I mentioned, niraparib and abiraterone versus abiraterone alone, was done in each of these cohorts to try to get an answer. Because like I said, there had been this question, can we use this synergistic approach to help all patients, or does it have to be a patient who has an HRR mutation? In this particular study, they found that people who did not have the mutations actually didn't seem to benefit from the combination of abiraterone and niraparib. And I think it's also important for us to remember that abiraterone in first-line mCRPC, if you haven't been exposed to an AR pathway inhibitor before, that's a really strong control arm. So kudos to the people that designed the trial, and actually all 3 of them still had these very strong control arms of standard of care, AR pathway inhibitor, as being the benchmark that they needed to beat. So that's, I think, really important and a nice design. The people who did not have the mutations, as I said, did not benefit. But the people who had BRCA1, BRCA2, some of these other HR mutations in that cohort 1 absolutely seemed to benefit from the combination of niraparib and abiraterone, even as compared to abiraterone alone, that really strong control arm. And so this combination is approved for people who have BRCA1 and BRCA2 mutations in that first-line mCRPC setting. It's interesting, this drug is actually a combination pill, so you can get your niraparib and your abiraterone in one pill. Another study that is, I think, really important in this setting, and there were 3 registration trials, is the PROPEL trial. Now, this was also looking at the mCRPC setting, but enrolled patients as a single all-comer cohort. So within this trial, they did know after people were enrolled and randomized whether or not they had HR mutations, but it wasn't something that they needed to have in order to get into the study to be in a certain cohort. So it's an all-comer population. In this first-line mCRPC study, patients were randomized to olaparib and abiraterone versus abiraterone alone. Again, really a strong control arm. So to beat that standard of care control arm, there would need to be something happening here in a very positive way. So what they found is that RPFS, radiographic progression-free survival, did absolutely favor the combination of olaparib and abiraterone versus abiraterone alone. And this was particularly beneficial in patients who had BRCA1 and BRCA2, but interestingly did seem to show a benefit perhaps in the all-comer intention to treat population. But just to emphasize, the label here is for the BRCA1 and BRCA2 population, but it was, I think, very provocative that it seemed in the intention to treat all-comer population there may be a benefit by RPFS that was statistically significant. Overall survival data still maturing, but a strong trend here, particularly in the BRCA1, BRCA2 population, to favoring that combination. So the third trial, TALAPRO-2. So this is, again, first-line mCRPC patients, and This is actually this is an all-comers population as well, and in this study, they did do this prospective genetic testing, so they knew patients' HRR status or whether they had these mutations or not going into the study. Patients were randomized to enzalutamide and talazoparib versus enzalutamide alone. In this case, we have a different partner, enzalutamide, but again, without any exposure to AR pathway inhibitors in an earlier setting, this is a really strong control arm, so I think an important thing for us to consider. In this study, they had an HRR population that very clearly seemed to benefit from the combination of talazoparib and enzalutamide versus enzalutamide alone. And so there's actually an FDA approval around this, not just for BRCA1, BRCA2, but for all HRR mutations included in the study. But recently, overall survival data and RPFS data also suggest that there may be an all-comers intention to treat benefit here too, both for RPFS as well as for overall survival. So I think a lot of questions still remain. The labels for these three combinations are pretty specific, with the abiraterone olaparib and abiraterone niraparib being for BRCA1 and BRCA2 patients, and enzalutamide and talazoparib being for patients with HRR alterations. But who knows if this may change, because that overall survival benefit in the all-comers population for TALAPRO-2 is pretty new information. It just came out at GU ASCO.
Great, that was a really comprehensive overview of those three important studies. And so now we're talking about first-line setting, which is really exciting. Again, drives home the point that we really need to have the results of these genetic tests. One point that I find somewhat confusing is what is appropriate for patients to have had in the metastatic hormone-sensitive setting to allow them to be able to get these drugs now. So in your practice, if you had a patient come in who had received abiraterone or enzalutamide and then progressed to castration resistance, are they still eligible? Do we know?
Yeah, so this is a great question, and we don't actually have perfect data. I guess I will advertise a trial that I have currently ongoing. It's open at this point in time. It's for patients who have had prior exposure to abiraterone. And if they have an HRR mutation, they're randomized to treatment with talazoparib and enzalutamide, so switching the partner, versus talazoparib alone, to understand if there is some synergy between these agents and whether we should switch the partner and do the combination, or whether a single agent PARP is sufficient and is just as good with less toxicity. But we don't know the answer. I think in real practice, if I have a patient with a BRCA2 mutation, I probably will talk to them about the combination here, even after a prior exposure to an AR pathway inhibitor, because the possibility of synergy is so high for those BRCA2 mutation patients, especially, that I wouldn't want to lose the benefit. I at least want to have the conversation with patients, but using a single agent PARP is also an option here.
Do you change that based on how rapidly they progressed or how widely metastatic? Does that change you to maybe do docetaxel or platinum-based chemo versus PARP? Or?
Yeah, if it's a really rapidly progressive visceral crisis, cord compression, then often we're going to use things like docetaxel. But what's so interesting to me is the Triton-3 trial that you talked about. There was a randomization there in the control arm. This was our only comparison of docetaxel versus a PARP. And in that study, it was rucaparib, so a different PARP than is available in that mCRPC combination setting. But rucaparib beat docetaxel, hands down, in a BRCA1, BRCA2 ATM population. And so unless I'm in a visceral crisis, I really do favor using a PARP in a BRCA2 patient because I think that this targeted approach is really a meaningful one for these patients.
So as we kind of wrap up here, I want to talk a little bit about the adverse events associated with PARP inhibitors. We had talked previously about anemia. You keep hearing kind of anemia, and anemia requiring transfusion is a well-established risk of all of the PARP inhibitors, but we can see some other important side effects as well. So Dr. Morgans, can you talk a little bit about them, and then how we best monitor these patients, and then what we do if someone is having some adverse events in terms of decreasing the dose or stopping?
Sure. So I usually use a bit of a ramp up approach and have people kind of start at a little bit of a lower dose and kind of increase the dose over a week or sometimes even 2 weeks if the patient seems to especially have challenges around nausea, because I think these are pills that you're taking. There are multiple pills that they need to take every day, and sometimes they can have a little bit of nausea as they're just starting that treatment. And I think usually they're not finding themselves vomiting and having huge troubles, but sometimes, especially people with a more sensitive stomach, it helps to kind of ramp up, and then that nausea issue does seem to resolve for most patients within a few weeks. And sometimes we have a little Zofran or something else that we can use to kind of support that. But the real challenge for these patients is not necessarily a challenge, but the real safety concern here is cytopenias from my perspective. And so we do have patients come back for a CBC, usually 4 weeks after they start. This needs to be monitored with all of the PARPs and all of the PARP combinations. And if the patient is developing an anemia, we certainly try to understand if there are underlying factors that might be contributing. Does the patient have iron deficiency? Is there a B12 or folate deficiency? Is there some other issue going on here that we also need to deal with? And if it seems to be related solely to the PARP, then we can do a dose pause if we have to, a hold, and then restart per the package insert. There are clear guidances there, or maybe just a dose reduction for a week or two, and a gradual titrating up. For most of these cytopenia issues, they seem to resolve within the first 6 months, especially as we kind of find that right dose for the patient. So sometimes they need to be on not full dose, they just need to be on a dose reduction, like a -1 type dose, to keep them safe and well. But once you find the right dose, then the goal is to continue and to continue to have that effective treatment over time. I think my strategy with PARPs is that it's dose over time that I want to achieve. So if I have to do a slight dose reduction to continue that exposure, that treatment over time for patients, I think that's the goal, is to really to just continue that effective targeted treatment for as long as possible, especially with patients with BRCA mutations. But those are the big ones. Fatigue, this happens when patients are on ADT, so they can also get fatigue with this treatment as well as basically everything that we do for prostate cancer. So trying to, again, use dose reductions if absolutely necessary to get them to be stable and feel well on treatment, and always encouraging exercise, which I wish I could just bottle it and give them a pill for that, but that's the hardest one to do. But exercise does seem to help as well.
And anything unexpected when we're using these combination therapies, the androgen receptor pathway inhibitor and the PARP together, is that tolerable?
I think it is. We just need to find the right dose.
Yeah.
Excuse me. So sometimes for some patients, if maybe they have had exposure to chemotherapy in the past, or they have, underlying mild marrow dysfunction, maybe they have thalassemia, maybe they have a reason to have, some cytopenias to start, and they may be the patient that we need to just do a -1 dose and just keep things just slightly less than a full dose to keep them, again, that dose over time, sustained dosing. But I still think that the studies suggest that even when they have that slight dose reduction, they seem to get a similar benefit from treatment. So again, dose over time is the goal, and just dose reduce if needed.
Great. So I just really want to thank you all for attending the course. I know that today's session will be great following this, and I hope you all have excellent AUA meetings. I want to encourage you, again, please fill out the program evaluation. It's really important for us to be able to continue activities like this, and your feedback is really valuable. So thank you, everyone.
Thank you.
Thank you.